You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Karan Mohan.
Hello and welcome to another episode of All the Pieces. I'm your host, Dr. Karan Mohan, and today we'll be talking about hospice and palliative care. November is National Hospice and Palliative Care Month. Roughly 1.7 million individuals in this country are on hospice, and that is not any different from our communities as well. I have two very special guests with me, Dr. Bill Rippey and Cheryl Daniels, to talk more about it. Before we get started, I'd like to have you introduce yourself.
Sure. Thank you for having me. My name is Cheryl Daniels. I am the Director of Hospice and Palliative Care here at Mosaic Life Care, a nurse by trade, and it's my privilege to oversee the group.
Excellent.
And I'm Bill Rippey. I'm a internal medicine physician, and I do little bits and pieces of other things here, one of which is I'm the medical director of our hospice.
Excellent. I'm a hospitalist by trade, so between the three of us, I know there's a strong passion for end of life and palliative care and discussions in general. But just for the listeners out there, Cheryl, I'll turn this to you. What is the difference between hospice and palliative care?
Sure. Actually, hospice got started in the 1960s in Britain by Dame Cicely Saunders, and it all came about to help patients die with dignity, help allay somatic complaints, pain, suffering, family support. And it's obviously 1960s, it's gone on for a long time. And then after we established that, then we branched out into palliative care. Hospice, we say you're close to the end of your life. You probably have around 6 months, year maybe left before the end of your life. Palliative care starts earlier. This is the good news, is when you start having chronic conditions that you have trouble managing, maybe you're not getting around as well as you used to, palliative care is there to help you manage your symptoms, help your family support you, help with resources, and we're an integrated team. So not only does the patient get a nurse visit, the chaplains are part of our role, the social workers are part of our role, and we have bath aides and that kind of thing too, so that we can provide the whole gambit of help for the patient. So I guess a clear way to say that would be hospice is closer to the end of life, palliative care 2-3 years prior to, when you start really having those unmanaged chronic conditions.
Excellent. And Dr. Rippey, Cheryl mentioned that palliative care is different from hospice because it starts earlier. In your opinion, in your practice, when do you think is the right time for palliative care discussions to start?
Well, palliative care just basically means we're providing comfort for the patients and helping them get their lives organized in a way that they can be seeking comfort. So palliative care really is a part of practicing medicine from day one. But as people near the end of life, there's a specialty service that's called palliative care. We have a specialty trained physician in our organization, Dr. Charamuka, and several advanced practice nurses. And we usually think that palliative care starts about, if we can guess, about 3 years before we'd anticipate somebody dying. And the idea there would be to have the patient's doctors get some help with managing symptoms, pain, shortness of air, those kinds of things. And, some of our doctors, some of our advanced practice nurses aren't quite as comfortable using some of these medicines that we use in palliative care and hospice, and we're very comfortable with using those. And it's not uncommon that, particularly cancer patients, but we're branching out into cardiology for chronic congestive heart failure patients, and we're going into the pulmonary clinic for people with end-stage chronic obstructive lung disease. So people that we have a pretty good sense don't have that much time left, but aren't quite at the stage where we're ready to go to comfort care only. So in palliative care, we're still treating the underlying diseases. Really, the focus is kind of shifting more from aggressive treatment to comfort, but we haven't shifted all the way over to comfort, which is what happens in hospice.
Right.
Now, we'll still treat some illness in hospice, but the diagnosis that leads a person to hospice, we're really not treating aggressively that underlying disease. We're really focusing on comfort.
Right.
So in other words, if someone comes on hospice and they have cancer, we'll still treat their diabetes and still continue their thyroid medications and blood pressure medicines, but the main focus is how do we make you comfortable.
So that's a good point, and we'll just expand on that. What are some common misconceptions when people have about hospice or palliative care in general?
Well, it's a death sentence. And honestly, yes, we are all going to die. But people graduate from hospice. If we get you on hospice and we can improve your chronic condition management and you don't show decline, people graduate from hospice every day. The other thing I think is sometimes people don't realize that hospice is there to support your family and your caregiver support team, whoever that may be. Right. It's not only the patient going through this, it's the family, it's the kids, it's the nieces, the nephews, the aunts, the uncles, all of that stuff. So we're there to take care of the whole unit, the whole family unit. And we're there after the patient passes as well, too. We provide up to 18 months of grief support after the patient passes, so that family can get the full benefit of that. And then we've also got some wraparound programs. We at Mosaic, I've been here 47 years, and we are very progressive, and we offer.
She started when she was 5.
Thank you.
47 years. My goodness.
And
congratulations.
Thank you. And Mosaic has so many good wraparound programs, like, for example, the Care at Home program, which is a group of doctors and APRNs that go into patients' home, go into nursing facilities. When you're sick and you're not feeling well, the last thing you want to do is get out and go to your provider. So we are very blessed here that we can send providers out to see you in wherever you are, your home, your nursing home. And as Dr. Rippey said, with palliative care, that is so important because we're still actively treating those chronic conditions. And we can still adjust medicines. We can still teach you nutritional tips and tricks and those kinds of things. And we've got like I said, the Care at Home program that can do that. We also have a nurse-driven care management program called the Serious Illness Management Team. And that, again, is an interdisciplinary team of a social worker and a nurse and a non-clinical person. And they'll come to your home or your nursing facility, too. So as you start declining, they're really geared at having those advanced care planning conversations. Right. It's a special technique to have that. What do you want at the end of life? How do you want your last days to be lived out? How do you want that? And the other thing they can do is facilitate that conversation between the patient and the families. It's really hard. I'm a mom. It's really hard for me to go to my son and say, I'm tired. I don't want to take this medicine anymore. But the team can help facilitate those conversations. They can really help share with the family once we know what the patient wants. What is it we need to do? Are you gonna live out your last years at home? Do you need caregivers? Can you afford caregivers? Do we need to talk about facilities? So we've got all these wraparound services to make this life journey as painless as possible. As possible.
And I think one thing is very important that you mentioned is dignity.
Yes.
Right? There's a lot of all the bells and whistles that come with these programs, but the real crux of the issue is you're helping somebody in the most vulnerable state.
Yes.
And clearing those barriers, whether it be medical, psychological, because outside of the hospice medications or the end comfort care medications, it's about preserving that individual's dignity. And they're not just that disease process. They're not just a hospice patient.
Yeah.
There's an individual who's encountering the end of life.
Yeah. And dignity is in all shapes and forms. I mean, unless you take the time to really ask your patient, what is it do you want?
What matters?
What matters? Great. What matters? What's important? I mean, examples of that are just recently we had a hospice patient, and he was a non-commercial pilot, and he flew out of someplace in Nebraska, and he wanted to go back to that airport. And through the Mosaic van, we were able to arrange that. The nurses went with him. We loaded him in the van, and we were able to take him to that airport because that was what was important to him. And unless you have the skill set to really know how to navigate those conversations and then how to make it happen, it's hard. And so this team can do that. They've got the time. And that's something a little differently, too, because when we talk about the hustle bustle of a medical office, we understand why. I mean, you've got to see patients, you've got to treat them. But in palliative care, this team has more time. They have time to really sit down, look you in the eye, and really find out what is it that you want, what's important to you, and how can we make it happen, and how do we make you comfortable, and that kind of thing.
So I want to go back to one of the questions that you asked Cheryl, which is what are the most common misconceptions about hospice? And Cheryl did address that hospice, a lot of people think, and unfortunately a lot of caregivers think that hospice is just for the very end of life. And we certainly will take care of patients at any stage as they get close to the end of life. And if we get the patients within a day or two of when they're dying, we'll take care of them. But we have so much more to offer in hospice, and a lot of people are leaving things on the table that their insurance would pay for if they start late into hospice. And so hospice has kind of a bad connotation to it, as that's the place I go to die. And commonly that's the case, but Cheryl mentioned that we do graduate people out of the hospice program because particularly in some of the care facilities where the care may be a little bit suboptimal, our hospice people go in, really improve the care that they're getting, and patients do better. But we provide, Cheryl listed the services that we provide, but we provide equipment in people's homes, we provide social services, we provide spiritual care, we help the families do things. We make things happen for patients, and there are a number of patients who will get up to the 6 month time and even go beyond that. We have to keep justifying to insurance on why we'd keep them on. And but there's the biggest misconception is hospice is where you go to die.
Right.
And I tell my medical patients when we talk about hospice, I say, just ignore the word and view what we're proposing to you is more services in your home that don't cost you anything.
Right. And that's really the gist of it, is parse out the misconceptions and or the triggering words and show them the services, whether it's appropriate, for them. In your opinion, Dr. Rippey, I'll start with you. What is the one thing you wish everybody knew about hospice care in our communities?
Yeah, well, to start early. I mean, that's the biggest thing. One of the things that sets hospice care apart from most other things, we have a few things that are similar. SIM, our serious illness management that Cheryl mentioned, but we provide hospice care as a team. And so much, as you well know and are working on in our organization, much of our care is individual and broken up. So every patient we have, every 2 weeks we have a sit-down meeting with all the responsible people for the care of the patient, including our pharmacist and me, the care managing nurses, the bath aides come to that, social services, and we sit down and go patient by patient. It's a 4-hour meeting, and you're welcome to come sometime if you want to spend 4 hours with us. And but we go through, and it's and there are a lot of questions that get asked, a lot of answers that are given, a lot of different suggestions on nursing care that can be given, and so. We have a similar thing occurs in our tumor board where you have a multidisciplinary meeting. And one of the things about team meetings is that, not everybody has all the answers, but if you get a good team together, the answer's in the room. And so if we can do team care and for example, you all are starting to pilot a potential service on the hospitalists with a rounding at bedsides with a team rather than just individuals going in. And the expectation and hope would be that that'll improve care, improve communication, and just things work better when people can brainstorm together about what the best thing is.
Right. Cheryl, what do you think is the one thing you would like people to know?
Yeah, I really agree with Dr. Rippey, what he said about the team approach. And one thing I would add to that is this team has the time. They have the time to sit and listen and really hear you, hear what you want, hear what your family wants. And the other thing, as Dr. Rippey said too, the earlier you start, you build that relationship with the team, and you benefit more from it because the family gets to know the nurse, the social worker, and the bath aide and the chaplain, and we can really help build that communication, that relationship, and hopefully make this transition better, smoother,
seamless for the patient.
Yeah. It's the richest Medicare benefit there is. And I think people sometimes think money, money, money. Well, Medicare recipients have a right to hospice care. We will pay for your equipment, your medication. We pay for all team members that come and see you, and it's a given. Any Medicare recipient has that benefit, and there's not many benefits that Medicare recipients have that they don't have to pay a copay for, and this is one of them. And it's a wonderful benefit. It's absolutely, positively a wonderful benefit.
And most hospice workers across the United States, including ours, don't view this as just a job. They view this as a calling in life, and so they are very dedicated to the patients, and the patients get probably closer care from the caregivers in hospice than they've ever had in their life in many circumstances.
And I feel that I believe palliative care team members are truly a purpose in action.
Oh, yeah.
And they embody the spirit of their work in ways that I'm not discrediting any of the subspecialists or anything like that. I'm just saying they have a ethos that resonates across the board throughout the whole team. And it sounds to me, the palliative care team and the SIM program and the hospice care, they all seem to be on a continuum, right?
Yes.
And palliative care discussion doesn't beget you to getting a terminal diagnosis, but necessarily to start the discussion. So should you progress in a direction that your health is not going the right way, they can tap into all these resources along the way across the continuum.
Absolutely. And we are I can't say that enough. We are very blessed in this community to have the services that we do, because again, we're going to meet the patient wherever they are. If it's hard for them to get out, you know what? We've got a van. We're going to get you out. If it's hard for you to get to your doctor's appointment, we can have the APRNs go to your home and see you, go to the facility. It's just full service, I guess is a good way to describe it.
Yeah.
And part of our continuum is that there are same people in all of these services. Cheryl leads the bulk of the services, but our home health is located in the same facility that our hospice is. Our SIM team meets there, and so we have a very strong end-of-life continuum, so that we don't have these break points where palliative leaves off and hospice steps in, or home health. The people are all right there with each other and can ask questions and that kind of thing. It's kind of like in our medical office. We all kind of sit close to each other, the access reps and our nurses and the doctors, and we have a care manager in the office, and we have a psychologist in the office, and when you're co-located there, one of the big things that has changed over the years in practicing medicine is that we do it much more as a team nowadays, and this is just a perfect example of that. And as we mentioned before, we're trying to get the inpatient care to be working as a team as well, because it's just better care when you work as a team.
And Dr. Rippey mentioned the IDG, and it takes all of our brains to come up. I mean, everybody is equal on the team. We may be talking, in fact, today we had IDG and we talked about a difficult patient.
What is IDG?
Interdisciplinary group, where we sit down, like Dr. Rippey explained, and talked about all the patients and all the disciplines are there.
Right.
We had a patient that we were trying to work through an issue with. Her husband was still working. She needed additional care. And actually, it was the bath aide that came up with a tremendous idea. And that's what happens with this team. Everybody's on the same playing field. Everybody's ideas are valued and appreciated, and it's wonderful. In fact, that's why I'm still working. I had the hospice.
47 years and going.
My hospice was always on my bucket list, and 2 years ago I had the opportunity to do it, so I decided to stay.
And you're better for it.
Oh, thank you.
I mean it. I can, as a hospice, I can tell you, palliative care services, hospice care services, is a tremendous value for patients who need it, because it makes their end-of-life process, in whatever capacity, the smoothest they can have. We can't take back the diseases that is killing them, unfortunately, but this is one of those things that the passage, the transition points, which are so critical in keeping everybody in the loop, especially the families. I can tell you from personal experience, it's a tremendous experience from the provider side, from the physician side, and thank you for that. Dr. Rippey, Can anybody start palliative care discussions, or does it have to be a provider?
Anybody inside of our medical complex, is that what you're asking?
Yeah.
Anybody could start if they feel comfortable doing it. I mean, palliative care really is just how do I make you more comfortable?
Right.
And so if someone, we want people to have their mindset on how do we make our patients more comfortable and have an awareness of what all's available inside of the organization, hence this podcast and some of the other information we have. The better our employees, our caregivers are at understanding what all we do in the organization, the better we can get the patients filtered to the right place in the organization. So anyone can start the conversation, but it's kind of if they feel like, well, I'd really like to do something to make this person more comfortable, then they just kind of need to know how to reach out, and usually it's going to be the nurses on the floor or the care managers on the floor. The doctors will know a lot about it. We have a handout that is available on the floors. The care managers have, but they're available on the floors, available in the clinics. And we've had it in our hospice newsletter, but Cheryl's got, we've had, 1,500 copies
Yes.
made already, so we're circulating it widely, it's titled Starting Hospice Early. It's a one-page document, kind of lists all the things we do and why it should make sense to patients to start hospice early. And it would behoove all of our caregivers to get a copy and read it themselves, because I think a lot of the caregivers who have this notion that hospice is where you go to die will kind of have a little different idea about hospice when they read through that. So yeah, anyone can start it, and if nothing else, people can find where those handouts are and give them to patients. And one of the things I think happens commonly in patient care, and our organization, ever since we went to electronic records, has been pretty good about giving, in our outpatient side and on our inpatient side, giving people handout information about what's happened at their visit. And a lot of times people kind of hear what we're saying them, but kind of don't, and then don't understand it. And so if we can say what we mean to say and then hand them something that says, kind of here's what we said, so that they can go back and read it and digest it at their leisure, I think that's beneficial. So that handout we're disseminating widely in the organization, using it as a educational piece for our staff and for our patients. I mean, it's primarily designed for our patients, but I think a lot of our caregivers would benefit from reading it too.
And we'll try to link that document to this podcast release, so our listeners, if they're in the community and curious, they can take a look at it too.
Yeah, and the other thing that Dr. Rippey, when he talked earlier about palliative care going into the different physician clinics, pulmonary and oncology, the reason we do that is to make the patient and family feel comfortable. You may have just gotten a new diagnosis. Maybe you've been diagnosed with COPD or a cancer diagnosis, and you're comfortable with that provider. You feel comfortable in that clinic. We have the palliative care specialists, the doctors, and the APRNs going there, so you don't have to go to a different environment where you don't feel comfortable. So we can help explain palliative care to you in a setting that you already know and answer questions and really talk about it, give you time to think about it. We do follow-ups to answer questions because, as Dr. Rippey alluded to, we give a lot of stuff, a lot of information, which is great, but you can't digest it all. So you may need to go home and have a conversation, and then we can follow back up and say, hey, have you had time to look at this? Have you had time to read it? What questions do you have? How can we help you?
And Cheryl, we certainly don't intend to go through it, but Cheryl has brought an admission packet that we have for hospice, and you can see it is thick, has all kinds of different things in it, and so our caregivers who go into the patient's homes or at the nursing facility, wherever they are, will talk to them about all this information that we think they should know. There's some forms that people have to sign, but then they leave the packet behind, and so there's no way that someone who hasn't been really exposed to this is going to understand everything. And even reading through the packet, they still won't understand everything. And so it's a process of bringing people around to have a knowledge of what we do, but leaving written material behind is really
Right.
Very important.
You know, and the other thing we've done too, and I don't know if we could do a link or not, is we develop what we call rack cards. And the reason we do this, again, is to make patients and families feel comfortable. If you've got somebody coming to your home and you have no clue who they are,
Right.
we pass these out. It's pictures, so you feel comfortable who you're letting into your
Sure.
home. The other piece of it is, on the back side of it, each program has one with the pictures of the people providing the service. And then on the other side, it's a description of the service. So you know exactly why that person's coming to see you, whether it be an APRN to do a provider level visit, whether it be a palliative care physician to come and talk to you about your complaints, your chronic conditions, how can we help you. And again, it's all about making the patients and families comfortable, because if you don't know somebody, we want to give you the picture as a resource to really make
That's
you
quite
feel
helpful.
comfortable. Yeah.
And we figured that if you can do that when you get your windshield replaced, we can do it here too. So.
Absolutely. It's palliative care flyers, you know.
Yeah.
Any way to get the word out.
Yeah. Oh, yeah.
Anything else you would like to share with our listeners today that you think would be beneficial to them?
I think it's nice to have somebody be the buffer and help the facilitator. I'm going to use the word facilitator. I think it's nice to use these services to help facilitate conversations between patients and families.
Right.
We talk about the good stuff. We're coming up on the holidays. Families are going to be together a lot. But how many times do you talk about, do you have an advance directive? How do you want to spend the end of your life? And we never, ever know when that's going to happen to you.
Right.
You don't know. It's never too early to have those documents in place. It's never too early to have those conversations. It's going to happen. It's
Right.
inevitable. And I think it's nice to have a trained group of folks that can help facilitate those conversations.
I agree.
Yeah.
Dr. Rippey?
One of the multiple diagnoses that we see on hospice in particular is dementia of different types.
Right.
And there is a book that if anyone is dealing with dementia, there is one book out there that is head and shoulders the best book for caregivers of people with dementia. My wife has a progressive dementia, and I got this book for all my children. Of course, I deal with it every day in my practice. The book is called The 36-Hour Day. It's and the reason for that is the caregivers of people with dementia feel like they're spending 36 hours in their day trying to get everything done that needs to be done. And you can get that on Amazon, and it's written by medical people. It's almost like an encyclopedia of all the things that are available that you should look for in your communities, look for nationally. But it also describes all the different types of dementias and stages that people go through. And when caregivers are educated as to what to expect, and of course with all the diagnoses we try to do that for all of our patients, say here's what we should be looking for, here's what we do. But when caregivers are educated what to expect, it makes it a lot easier for them. And a lot of times, particularly with dementia, a lot of times family members want to kind of get in the face of the person who's not getting the right answers or saying the wrong thing, and,
Right.
and go. And the answer is that's not what you do. But there's, you kind of redirect them. But this book is an incredible handbook for people with dealing with dementia. It's called The 36-Hour Day.
Appreciate that, and thank you for that recommendation. Well, there you have it, folks. A beautiful discussion about a somewhat transitory time in some of our patients' lives, and the amount of services that Mosaic provides on the continuum of palliative care, whether it be the serious illness management program, hospice care, and even down to comfort care, which is truly the end of life. We have it all, and we have a great team that leads it in a true interdisciplinary way. If you have any questions regarding hospice or get some information, there'll be some links provided with the podcast, but there's always Cheryl Daniels and Dr. Bill Rippey here to lead and guide the way. And once again, I thank you for your time and attention. Take care. Brush your hair.
Thank you.